So we will begin with glycolytic enzyme deficiencies. You remember this famous glycolytic map? So let's begin with a question. Name the 3 most known glycolytic enzymes. Well, those were the 3 that I've already marked for you. And the first one is hexokinase, the second one is phosphofructokinase, and the last one is pyruvate kinase. So those are key steps in glycolytic pathway. We also talked about this important area that in the red cells, as they pass through the tissues, 1,3-diphosphoglycerate is converted to 2,3-diphosphoglycerate, and then we return back to 3-phosphoglycerate as the red cells leave the tissues and they get back to the lung. So hexokinase converts glucose to glucose 6-phosphate. Fructose 6-phosphate is acted upon by phosphofructokinase, and we make fructose 1,6-bisphosphate. Finally, the last enzyme of glycolysis is pyruvate kinase that converts phosphoenol pyruvate to pyruvate. Let's look at this case scenario. A 4-year-old Caucasian girl is being evaluated for anemia and jaundice. Lab results are significant for increased reticulocytes, reduced serum haptoglobin, and increased urinary hemosiderines. No sickle cells or spherocytes are identifiable in the child's blood. She has a mild splenomegaly but lacks hepatomegaly. She has no history of any recurrent infections. So let's keep this case scenario in the background. Let me ask you the first question. What is the best descriptive term for the findings in this child? Anemia, jaundice, reduced haptoglobin, increased reticulocytic index. The best descriptive term is hemolytic anemia. This is a good description for hemolytic anemia. So what are your first impression, top differentials? First impression top differential, based on the age of the patient, include many genetic defects. For most part, many of them are enzymatic defects. To name the top differentials, as a first impression again, hexokinase deficiency, phosphofructokinase deficiency, pyruvate kinase deficiency, glucose 6-phosphate dehydrogenase deficiency, hereditary spherocytosis, sickle cell anemia, and beta thalassemia. You can also add alpha thalassemia, but it's kind of unlikely. It's a much more serious condition and less commonly tested than beta thalassemia. But if you want to add that, that would be fine for your first impression. Now, what are your second impression top differentials? Which one you can rule out? Several of them you can rule out if you look at the case scenario more closely. For instance, you can rule out glucose 6-phosphate dehydrogenase deficiency because this one is X-linked. But you have a girl in here. Secondly, you mostly see this among the Afro-Americans or individuals of the Mediterranean origin. So that one can be ruled out. Another reason is that the hemolysis of glucose 6-phosphate dehydrogenase deficiency is episodic and quite often follows after administration of oxidizing agents. In hereditary spherocytosis, you identify spherocytes. Those are smaller red cells that are spherical in shape. Sickle cell disease, again, is ruled out because you don't have any sickle cells, and again, it's mostly seen in Afro-Americans, and we have a Caucasian girl in here. Finally, beta thalassemia is ruled out because beta thalassemia is mostly seen among the Mediterraneans, Arabs, and Asians, and also in the areas that malaria used to be endemic in the past. So we can rule out all those. So this brings us to our final top differentials. Those are hexokinase deficiency, phosphofructokinase deficiency, and pyruvate kinase deficiency. Now these three, I call them a triad. Triad is a term that I've coined for three items that they have so much in common and they have some contrasts among them. And of course, the test makers love the triads, and quite often they like to make good case scenarios on them for you. So what makes these three enzyme deficiencies similar? Makes them a triad. They are all key glycolytic enzyme deficiencies. All three cause hemolytic anemia. If you want to add one more, all three are autosomal recessive conditions. Which of the three is the most common deficiency and is the most commonly tested one on your exam? That one is pyruvate kinase deficiency, which is the last enzyme of the glycolysis. What is by far the most common cause of hemolytic anemia as a result of enzyme deficiency? You have a patient who has hemolytic anemia. We know it's an enzyme deficiency. What would be your answer? I give you a hint. Is X linked? Well, the answer is glucose 6-phosphate dehydrogenase deficiency. X-linked condition, more common, at least in the USA, among the Afro-Americans. What unique clinical finding will set phosphofructokinase deficiency apart from the other two glycolytic deficiencies? Rhabdomyolysis, as a result of glycogen buildup in the cytoplasm of the muscle cells. As a result of rhabdomyolysis, patients have myoglobinemia, myoglobinuria, serum creatine kinase level increases. Creatine, which is usually confined to the striated muscles as a result of rhabdomyolysis, may be released into the plasma, and you can identify that in the serum as well. This disease is also called glycogen storage disease number 7. In which of these deficiencies the level of 2,3-diphosphoglycerate decreases in the red cells? Actually, in two of them, in hexokinase deficiency and phosphofructokinase deficiency. These two deficiencies are before the level of 2,3-diphosphoglycerate in the red cells. If these two are deficient, 1,3-diphosphoglycerate becomes deficient. 1,3-diphosphoglycerate becomes deficient, 2,3-diphosphoglycerate level goes down. 2,3-diphosphoglycerate level goes down, the red cells, as they pass through the tissues, will stick very firmly to the oxygen, and they will not release the oxygen properly to the tissues. So we may get tissue anoxia. We have discussed these issues during the last hour of the lecture, so I will not dwell on it anymore for you. So why patients with hexokinase deficiency present with the most profound hemolytic anemia? Any ideas? The reason is that hexokinase is not an exclusively glycolytic enzyme. There are several other pathways, at least 2 other pathways in the body that they require hexokinase. One would be glycogen synthesis and degradation, and the other one would be the hexose monophosphate shunt. The one which is important in this regard is the hexose monophosphate shunt. Now the red cells are the only tissues in the body that they only can utilize glucose. In hexose monophosphate shunt, starting with glucose and glucose 6-phosphate, we're going to end up making 5 carbon sugars, and also we make NADPH. NADPH is a reducing compound. It's essential for the synthesis of lipids and fats. But at the same time, because of that reducing effect that it has, it shields the red cells against the oxidizing agents. In the absence of the NADPH, the oxidizing agents will damage the membrane of the red cells. So red cells in hexokinase deficiency, they have 2 reasons to get destroyed. One is the fact that as a result of that deficiency, the red cells cannot utilize glucose to make ATP. Therefore, they will not have functional sodium-potassium ATPase pump on them. Sodium stays inside the red cells and water will follow as a result of osmotic pressure into the red cells and causes hemolysis. The second reason being that NADPH of the hexose monophosphate shunt shields the red cells against the oxidizing damages of the oxidants. In which of the following conditions there is a left shift of the hemoglobin dissociation curve? Actually, in 2 of them, there is a left shift, in hexokinase and in phosphofructokinase deficiencies. The reason being, in both of these conditions, the level of 2,3-diphosphoglycerate in the red cells is low. Patients in which of the following conditions will be more benefited from oxygen therapy? Those are going to be patients with pyruvate kinase deficiency, because in this condition we're going to get a right shift of oxygen hemoglobin dissociation curve, and increasing tension of the oxygen will improve the oxygenation of the hemoglobin in these patients. Summarize major associations of the left and right hemoglobin oxygen dissociation curve. Well, the solid line shows the normal dissociation curve. The line on the left side is for the left shift and on the right for the right shift. As you can tell, any condition that causes the right shift, in order to assume the same saturation of hemoglobin with oxygen, you have to increase the tension of the oxygen in the plasma. So pyruvate kinase is the only condition that causes the right shift. Hexokinase and PFK deficiencies, they cause left shift. So let's look at the main associations of the right shift. Those are going to be high 2,3-diphosphoglycerate in red cells, low hemoglobin oxygen affinity, high unloading of the oxygen to the tissues, increased acidity, increased PCO2, high temperature, high altitude, chronic hypoxia, COPD, and lung diseases. On the other hand, the diametric opposite of most of these conditions causes a left shift. Low 2,3-diphosphoglycerate in the red cells, high hemoglobin oxygen affinity, low unloading of the oxygen, carbon monoxide poisoning, methemoglobinemia, fetal hemoglobin, and of course the 2 enzyme deficiencies of hexokinase and phosphofructokinase. Now let's summarize. What makes them similar as part of the triad is the fact that they are all glycolytic enzymes or glycolytic enzyme deficiencies. All of them are autosomal recessive deficiencies. Deficiency of all causes hemolytic anemia as a result of low ATP in the red cells. Treatment options for all of them, to summarize what we have discussed before, include blood transfusion, splenectomy, and folic acid administration. On the other hand, hexokinase deficiency causes by far the most serious hemolytic anemia among the 3. It also causes a left shift on the hemoglobin oxygen dissociation curve. Phosphofructokinase deficiency